fact, you can give someone a survivorship care plan, but just giving them doesn't mean that it's going to happen. And one area where I always see it is maybe there's no information about family history, or maybe there's information and there's quite a bit of family history, but there's nothing that says, oh, they were ever had genetic testing, or, oh, they were ever referred. So the intent is so good because it's to really take that time out when they're through with active treatment.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello, and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS, and today we're talking with Suzanne Mahon, Professor Emeritus in the Division of Hematology and Oncology at St. Louis University in Missouri, about what oncology nurses need to know about breast cancer survivorship. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome back. Thanks so much for joining us again today, Suzanne.
Well, thank you for having me back. This is a great topic. There's just so many things you can talk about.
As hopefully our listeners know, this is the final episode in this series, a site-specific series on breast cancer. And so today we're going to round it out with survivorship. So to start things off, can you provide us just with an overview of the current epidemiology of breast cancer in the United States? And what are the expected statistics for 2025? How many people are going to be living with breast cancer?
I'm an epidemiology person, but I always think it's really important to understand the actual numbers of people that are affected. So, as we said in one of the earlier podcasts, about 316,000 individuals assigned female are going to be diagnosed with breast cancer and invasive breast cancer, and another probably close to 60,000 cases of DCIS. So that's a lot of people that are going to be diagnosed. And unfortunately, still close to 43,000 of those are going to die from breast cancer this year. But you have to think about all the strides that we've made in breast cancer, and it is no longer a death sentence. And I think that's really important to communicate to our patients, because we have probably more than 4 million breast cancer survivors in the U.S. on any given day. That is a lot of people that they may have had breast cancer a year ago. They may have had it 10 years ago. They may have had it 30 years ago, but they have all been impacted by it. And some are still probably being significantly impacted by it. And I think this is a place where nursing can really make a huge difference.
Absolutely. And so I think it's important as we start out this conversation of really honing in on what is that definition of cancer survivorship, and how should this definition shape the way that healthcare providers approach their care for individuals after their treatment is complete, or even if it's not complete.
And as we said earlier multiple times, breast cancer is a journey. You don't get over it in a few days. It is a long, long journey. The NCCN, and I think that's the definition that many, many people follow, is that individuals consider cancer survivor from the moment of diagnosis through the balance of their life. So we have people who are in active treatment, and then we have people that are maybe on kind of maintenance therapy. So in breast cancer, maybe, some endocrine blocking therapy. Then we have people who have completed therapy and are still probably living with some of the effects of that treatment. So it encompasses a lot of people.
Absolutely. And, I always think it's important to remember that even if that's the definition that we're working with, patients themselves might not identify as a survivor. They might not like that term, depending on where they are in their journey, as you mentioned. So just always important to be sensitive and be mindful of that.
I think the biggest thing is to really communicate is that people are living with breast cancer for a long, long periods of time. And a lot of that with really good quality overall.
Absolutely. So the NCCN and the Commission on Cancer, or the COC, they both have recommendations for providing survivorship care, also including sometimes providing specifically a survivorship care plan for breast cancer survivors. Can you explain a little bit about what should be included in a comprehensive care plan if we are offering those to our breast cancer survivors?
So the idea of survivorship has been around for a long time. And at the 12th ONS meeting, Deborah Boyle and Hugh Fitzsimmons and Susie Lee talked about survivorship. And so the concept is not new, but it took until 2015 for the College of Surgeons to decide that, yes, we should give survivorship care and care plans. And the basic components would be that there would be a summary of the personal and family history of cancer, the specifics of the diagnosis, like the pathology, and, some treatment details, not just that they got chemotherapy, but maybe the dose and the number of rounds and whatnot. That basic information. And then it was to also is to include what's that follow-up schedule going to look like? How often do you need to see this provider? And when do you need to get this exam or this test? And then ideally, it would include some possible late side effects or long-term effects that providers should be concerned about or watching for, trying to intervene as early as possible to be a little bit more proactive. What are some health promotion things such as diet or exercise? So it is somewhat specific, but not exactly. So institutions could kind of decide how they wanted to implement that, how much detail they, as I said, the part about the treatment and follow-up was fairly structured. The rest, maybe not quite as structured, but there's, I think, still a lot of disconnect. You can give someone a survivorship care plan, but just giving them doesn't mean that it's going to happen. And one area where I always see it is maybe there's no information about family history, or maybe there's information and there's quite a bit of family history, but there's nothing that says, oh, they were ever had genetic testing or, oh, they were ever referred. So the intent is so good because it's to really take that time out when they're through with active treatment and, try to help give the patient some guidance as to what to expect down the line. But you can't just give it. You have to kind of explain it and implement it and make sure the patient understands it.
Absolutely. My practice, what I noticed is that it sounds simple enough. Let's create a care plan and let's sit down and talk with them. But it didn't always end up being that simple. So I don't know if you've seen that or if you could discuss some of the barriers or the challenges that you've observed to ensure that that happens, that we create that care plan and that we're able to sit down and talk to the patient about it.
So it's not just the making it, it's the then being sure that it's comprehensive and then making sure that the patient understands it. And I think one of the biggest things is, we always kind of jokingly said, well, who's the captain of the ship? Who's making sure that all of this gets done? Because the idea of the care plan is that these patients, they encounter multiple medical disciplines and other subspecialties. And we want to make sure that everybody knows what the other person is doing. And that's the ideal. But at the end of the day, someone needs to be sure that everybody actually did what they were supposed to do. And I think one of the most, when you start out, and what patients are concerned about is that follow-up schedule. So once they finish active treatment, first of all, we have to recognize that that is a scary, scary time for patients. If they're getting chemotherapy or radiation therapy or something, they're in and out of the office every week or two. They get used to, they're like, oh, these healthcare providers are looking at me all the time. They're going to catch a problem. And then we say, well, you can come back in 3 months. And that is like really scary because they feel like that safety net that they were so depending on has kind of been pulled away. But it's also trying to kind of make that schedule so one, they can get to everything and that nothing gets lost. And I think another thing you need to kind of think about, I work in an urban area, but we see a lot of patients from very rural areas. So every time you ask a patient to come in for an appointment, they're probably taking a full day off work. Their family member's probably taking a full day off of work. They have fuel costs and all sorts of things. And so we want to make sure that that schedule is reasonable, that they can get to it and that it covers all the bases. So an individual might be seeing a plastic surgeon, a breast surgeon, radiation therapy, medical oncology. That's like a lot of subspecialists. And they may be on the rotating schedule. Maybe you see this one every 6 months and you see this one every 3 months. And so someone has to kind of balance that schedule out for patients. They need to have follow-up imaging scheduled. If they've had breast conserving surgery, they need a mammogram on the affected side 6 months later. But for many patients, then they're almost due for their bilateral again. And if they've had a mastectomy, then they need one and they only had a unilateral, then they need it on the other side. Those need to be a diagnostic imaging. That needs to be ordered. We need to be sure that they get their gynecologic exams, especially if they're on tamoxifen. We need to be sure that that's actually scheduled and happening. Bone density testing, ideally that's done before treatment starts, but in a lot of cases it falls through the cracks. But then, if you have an individual on an aromatase inhibitor or many of our individuals who have had a very early menopause, they're at risk for osteoporosis. So we need to be sure that that's getting ordered. And ironically, things that patients want really aren't evidence-based. There's really no reason to do a lot of blood work or PET scans or CAT scans unless, you're concerned about metastatic disease. There's really nothing out there that says that that's going to increase survival or decrease mortality. Another area where I think it's easy to fall through the cracks in terms of, and why it's complicated, is these patients are at risk for other cancers. They have at least average risk for colon cancer and melanoma and gynecologic cancers and whatnot. So making sure that they get all that appropriate screening. There's nothing to me sadder than, we take care of someone's breast cancer and then they never get to colonoscopy and present with a later stage colon cancer that we could have prevented had we had them engaged in screening. So doing all of that. And then also, I think it's an important time to take that time out and say, if you've had germline testing and there's a pathogenic variant, those patients are going to have very complicated screening schedules. And who's going to make sure that that gets done? Or who's going to make sure that that schedule and recommendations are appropriate? Or has this patient fallen through the cracks? Maybe they chose not to do genetic testing earlier, but now they're ready, or now something has changed and they're appropriate for it. So those are all things that need to be managed. That's just the tip of the iceberg of what these patients need.
Absolutely. That can end up on that survivorship care plan document if your site is able to create those and have that discussion, and really can serve as that anchoring sort of reminder of what needs to happen next, or what is the expected frequency of certain exams, because they likely will happen at a certain cadence and not just one and then be done with it. I also, you mentioned this, but I really think it also can serve for the primary care physician, for their regular routine doctor. Hopefully they haven't lost sight of that while they've been getting their care for their cancer, which oftentimes, patients like to just have one doctor handle it all. And I certainly understand why that would be convenient. But when we are kind of releasing them to this more of a survivorship phase of their care, we need to make sure that their primary care doctor understands what they went through and understands what we're recommending as well, because they can certainly be a partner in making sure some of those follow-up things, as you mentioned, routine screening for other cancers, knowing that a fair amount of patients who do have breast cancer are younger. And so they still have put many of years of risk for all of the other types of cancer that we know are out there and that we can screen for. So all great reminders that you've provided here.
I think it's really important to know who's going to take responsibility for it. And I think a lot of times that nurses organizing that is maybe one of the best things, because they're looking at the whole picture and not just what the plastics person does or just what the breast surgeon does. But everyone needs to be clear, well, primary care takes care of the routine screening, but we take care of this. And so organizing that so the patient knows and it's clear to all the providers what their job is really important.
Now, you mentioned it a little bit, but maybe we can dive in a little bit more specifically. Obviously, everyone's situation and their follow-up routine will be customized to them. But in general, what is the typical schedule for follow-up exams and surveillance for our survivors? And does that differ depending on kind of what their treatment included, whether they had surgery and mastectomy, or if they're on hormonal therapies, sort of in a longer-term maintenance type of phase?
It is very individualized. As a general rule, they're going to be seen by the breast surgeon probably every 4 to 6 months for a while. After about 5 years, a lot of times people are ready to say, okay, annually is okay. And eventually they may let that drop off. But it also depends on, did they have a mastectomy? Did they have breast conserving surgery? And then if they had reconstruction with an implant, how often do they see the plastic surgeon? Because they need to check integrity of the implant. So those schedules are really individualized. Radiation therapy might want to see them every 3 or 4 months for the first year or two, and then they may drop it to every 6 months, and then they may drop it off maybe to annually after a while. And if they're seeing radiation therapy, and then maybe see the breast surgeon on the opposite 6 months, so we kind of spread it around. If they're getting hormone blocking therapy, they are probably being seen every 3, 4, 6 months in the office. And I think this is a place where, an adherence nurse or someone, I don't know if that's exactly the right title, but the person who's kind of calling them to be sure that, are you still taking that regularly? Or do you have a lot of missed doses? Can you afford the drug? Are you having side effects? Because those patients are going to be on those medications for 5 to 10 years, and it's the cornerstone of their treatment. So we have to keep them on, ideally we want them on the medications. So the schedule initially, it will be more concentrated. And as they move further and further away from that diagnosis, it'll become less frequent. And once again, that's scary for patients. And we know that their anxiety ramps up a little bit right before and during those exams, and we need to be mindful of it. But they also get nervous when they're not being watched so closely. So, helping them to understand that we are watching them and these are people you can call with questions is really important.
Absolutely. Well, now let's move on a little bit into some of the longer term or even late effects of the breast cancer treatment that a patient may have received. What should we recommend patients monitor for? And how do we educate them on really what to watch for and kind of when to call, what's concerning? And then we'll go in more depth about each of these things after your response.
When you think about long term effects, I think you need to kind of think about that survivors can have both acute and long term chronic effects. And a lot of that depends on the specifics of the treatment they had. I think as oncology nurses, we're used to, we give you this chemotherapy or this agent, and these are the side effects. And this is what needs to be monitored while we're infusing it or giving it to you. And this is what you might see at home. And this is what you need to report. And we are very used to tailoring that portion of it to the patient. When you start talking about long term effects, some of them are carryovers from the acute phase, things like fatigue, cognitive changes, distress, anxiety, depression. They can experience those anywhere along the line. And just because they finish therapy doesn't mean that those are necessarily going to go away. So those could be both acute and kind of chronic or long term. And there are other things that we don't see immediately, or we might see a little earlier, like you might see lymphedema a little bit after surgery, but you can also see it years later. Things you might not see for a little while would be like a cardiovascular changes or osteoporosis. Those are things that you're going to see them. They're certainly, going to happen. Menopausal symptoms, issues with sexuality and fertility and body image. You might see them right away. You might see them later, and you might see them across the spectrum. So I think, you kind of need to be mindful that there's no timetable for some of these changes.
That really is a great reminder that they don't happen in any certain order or at necessarily any certain time. So sharing with our patients, giving them an awareness of what to watch for, but also not making them panic. There's a balance to strike there. So let's start with the cardiovascular risk that you mentioned. There's a notable increase of cardiovascular risk in breast cancer survivors, especially when they're treated with certain therapies. So how should oncology nurses approach cardiovascular health for these patients that we're caring for?
This is an example of why good survivorship care is so important. So we know the risk is increased, especially in those that are treated with anthracyclines, some of the hormone blocking therapies, and the HER2 blocking agents. And, to some extent, radiation therapy, although those techniques have gotten much, much better over the years. So the heart is not taking near the hit that it used to, so to speak, but it's still a risk there. And I think this is one where we've really come to have some awareness that this needs to be dealt with. First of all, you need to realize that a lot of people, especially if the average age of breast cancer is someone in their early to mid 60s, a lot of these individuals are going to already have underlying problems associated with cardiovascular disease. They may have hypertension or an elevated cholesterol. They may have diabetes or obesity and things like that. So they already have things that are not helping their cardiovascular health. And then you put on top of that they've had therapy that may have directly damaged the myocardium. I think this is an area where coordination is really important. First of all, being aware of, that's why that survivorship plan is so important. Did the patient have any of those therapies that put them at risk? And now there's kind of this area called cardio-oncology. So there's cardiologists who like to take care of our patients who've had therapy that increases their risk. And so making sure that somebody is paying attention to their cardiovascular health, whether it be their primary care or the cardio-oncologist, because it is something that earlier intervention is going to probably help. And to me, it's just very sad we took care of their cancer, but they became debilitated because of the effects of treatment. And a lot of those treatment, they can be mitigated. So this is one I think where people need to watch and be sure that they're referring sooner rather than later.
Now let's move on to lymphedema. Certainly another common issue that our breast cancer survivors deal with, especially if they had surgery, mastectomy, things like that. What preventative measures should nurses be discussing with their patients to help minimize the risk of developing lymphedema? And what should they do if they start to see those symptoms arise?
Lymphedema is certainly less in the age of sentinel lymph node as opposed to doing the aggressive lymph node dissections that were done 20, 30, 35 years ago. But, the incidence still runs anywhere from 10 to 40% of all women will have some degree of it. Now, that doesn't mean that they're going to have horrible lymphedema, but that they could have some. Ideally, prior to surgery, there's going to be baseline measurement of the limbs or certainly an early post-op. So we know what we're starting with. And then talking to patients about prevention, certainly to avoid venipuncture and blood pressures on the affected side to the extent that you possibly can. And then also educating them on what lymphedema looks like. I think people think that it's hitting edema, but it can't just be a little bit of swelling. We want to catch it earlier rather than later, because this is one where early intervention makes such a difference. It's also really important that people understand that risk of infection is higher. So, that hangnail or that small cut you get in the kitchen, no big deal for most people. It can be a big deal for them. So they need to really understand, if they're seeing redness or pain or streaking, any of those signs of infection, warm to touch in the affected limb, that they need to report that right away. We don't want them waiting days and days and days to tell us. We want to intervene with that. If patients develop lymphedema, I think that they should be in some kind of self-management, whether they do some manual drainage themselves or range of motion. And some of the breast surgeons now are really very on top of this and will automatically refer them to physical therapy to be sure that nothing is going on and to learn some of that self-management if they're affected at an early point. And I think we should not be slow to refer to physical therapy or an occupational therapist who's a lymphedema expert, because that early intervention really prevents the long-term problems and really getting these patients into a plan of regular exercise. And so they understand that it's every day for the rest of their lives.
So moving on to osteoporosis, which you also mentioned, how do we need to manage this in our breast cancer survivors, especially for those that have received certain chemotherapies or even hormone blocking therapies? What's the importance of regular bone density monitoring, and what are some treatments that they can consider?
Osteoporosis is this giant public health problem to begin with. 1 in 2 individuals assigned female birth will develop osteoporosis. So it's already this giant public health problem. And that's what we call primary osteoporosis. And it's this slow thinning of the bones, and the more fragile they become, then there's the increased risk for fracture. The diagnosis in and of itself is not the problem. The problem is if you fracture. And if the risk of fracture is higher, that's what disrupts quality of life. But individuals who've had chemotherapy or who have had a premature menopause in particular are at risk for secondary osteoporosis, which can occur much faster and it can be much worse. That's why we know that this large quantity of people are going to be at risk to begin with, but the risk is so much greater. So understanding, that's why I said if you could get bone density on all of our patients before we start therapy, then we kind of know where we started. But, women who've had an AI have a 2 to 4-fold increase in bone loss. It is significant. And understand that for the average woman, not someone diagnosed with cancer, in the first 5 years of menopause, they lose a quarter of their bone. So someone who's had an AI is going to lose even over and above that. And, as I said, our patients who've had chemotherapy that's caused either ovarian failure or they've experienced early menopause. So typically at the completion of therapy, to do that DEXA test and see where they're at. That will determine how quickly the next one is done. But if the DEXA shows a T-score of a negative 2.5, then we need to kind of consider that risk of fracture is very, very high, and that maybe we want to think about a bisphosphonate. But those are drugs that have a lot of side effects, and sometimes they are tolerated better than others. So trying everything we can do to keep that woman from losing any more bone so she doesn't get to that point is really important. So, first of all, really saying how much calcium their intake looks like. So they should probably be having about 1,200 milligrams of calcium a day. Now, if you drink milk and eat yogurt every day, it's probably not too hard to get to that. But if you don't do that, it might be really hard to get to that. So understanding how much you actually take. And we need vitamin D, and your needs for vitamin D increase as you age. So depending on your age, you can need anywhere from 400 to 1,000 international units a day. We also want people to maintain kind of a healthy weight, and we want a little bit more muscle mass. Then we want to, look at your diet and say, also, are you getting enough protein? because that helps support the bone. So I think one of the most important things you can do kind of at this point is really make sure that these patients are perhaps seen by a dietitian who can really help them sort through their diet and say, are you getting enough calcium? Are you getting enough vitamin D? Ideally, we would get that through food. But for people that can't get to that point, we need to then supplement them. And I think that education goes a long way. It also says to the patient, this is really important. It's so important we're sending you to this dietitian. We want you to understand that. And the same is true of weight-bearing exercise. They should be having daily physical activity, at least 30 to 45 minutes. And some of it should be strength training 2 or 3 times a week. That's another thing that we really need to talk to patients about. And then how are we going to prevent further problems? Well, if they're still using tobacco and smoking or vaping or whatever, to get them off of it. Alcohol is also one that, can be a bone robber, so to speak. So, minimizing their alcohol intake and really getting them out of that sedentary lifestyle. We really need them to be up and moving. So osteoporosis is a huge, big deal.
Thank you for all of that great information. As you said, it's a problem for potentially anybody, but the reasons to be concerned and the importance of checking into it are even more important for our patients, our breast cancer survivors. Now moving on to menopausal symptoms, particularly hot flashes. We know a large proportion of breast cancer survivors have to deal with this, especially based on the therapies either they've had or they are still on. So how can nurses help our breast cancer survivors to manage these symptoms? And what non-hormonal treatments should they consider?
Hot flashes are a big deal. So probably 50 to 85% of women with a diagnosis of breast cancer are going to be bothered and troubled by this, and some for quite a while because, the aromatase inhibitors and tamoxifen, as well as early menopause, all of those are things that can aggravate and compound it, in addition to the hot flashes that individuals who are assigned female are going to start experiencing in their 50s, no matter what. When we talk about prevention, there is now some evidence that physical activity helps. And so really trying to get people to engage in physical activity 30 to 45 minutes a day, because it's going to help with your osteoporosis and a whole host of other things, is really important. These patients cannot take hormone therapy because many of their breast cancers were dependent on and growing because of estrogen and progesterone. So they're on estrogen blocking therapy. That's not going to be an option. The evidence suggests that the gabapentinoids have a pretty high side effect and don't really work. Paroxetine should not be used in individuals with tamoxifen. So another one that's not a good choice for our patients. And this is one where I think people are frequently willing to try all sorts of supplement things for which we don't really understand safety profiles. So someone on the team needs to be assessing and making sure that we're aware of what patients are using and really discourage the use of that because we don't understand the purity and the side effect issues. So then you're left with, well, what can you do? So as I said, physical exercise may help prevent it. For years, literature said, well, use fans and dress in layers and whatnot. And there's truly no evidence that that works. There's probably no evidence that it hurts, but there's probably none that it actually works. For some patients, hypnosis or cognitive behavioral therapy can be helpful. But this is one where we kind of need to take care of it because if the hot flashes become bad, then they don't sleep. Then we have a whole nother set of problems that come from that. And the adherence to the hormone blocking therapy or like the aromatase inhibitors will drop off. And then that's going to get us into trouble with we're not treating their disease. So acting earlier rather than later. And even though you don't want to really keep adding medications to these patients, this is a group that probably would benefit from venlafaxine. And they can go up to like 75 milligrams dose, but start really low, 25 or 37.5 milligrams, and gradually increase it. But the kicker with this is that patients take it for a day or two and they say, oh, I took it and my hot flashes didn't get any better. It takes 4 to 6 to 8 weeks before we really know if it's going to work. So, kind of being that cheerleader and getting them to stay with it is important, but it's important because we need them to stay on those other therapies. And it is a distressing symptom that we may not be able to make it completely go away, but we can make it not as intense to improve their quality of life.
Absolutely. And that's exactly what I was thinking of. It's one of those symptoms that it's not life threatening, but it's certainly life altering. And it's a quality of life issue that if it can't be managed or it's not managed at all, really can impact patients. And as you mentioned, maybe make them not want to take their medication that really is helping to treat their cancer or keep it at bay. And so something not to be overlooked or to minimize, and certainly worth asking intentionally how patients, if they're experiencing hot flashes, and how they're dealing with them every time they come in for a visit. Along those same lines, not life-threatening, but certainly life-altering, many breast cancer patients and survivors, they face sexual health and fertility issues. So can you discuss how nurses can address this concern and bring up these questions about sexual health when they are seeing our...
And it's probably one or the other or both, probably about 100%. The effects can be different, but it's out there. And I always say it's the elephant in the room. And if you think that the breast surgeon or the radiation therapist is talking to them about it, maybe they are, but not likely. So somebody has to take responsibility and ask the patient about it. And I think you also need to realize things like menopausal symptoms or depression or sexuality or fertility, patients feel guilty bringing those up because here they are at a visit and, we're talking about everything we can do to keep them alive. And they're like, well, I shouldn't complain about that because I should be grateful to be alive. Certainly our goal is to keep them alive, but also they are often reticent to do this because they don't want to feel like they're not grateful for everything that's gone on. And so it's the elephant in the room. And I think kind of jump in if they've had chemotherapy. Are you having trouble with vaginal dryness? Because there's a good chance that an early menopause is going to result in that. And then we can perhaps address that with some kind of lubricants. And a lot of times too, that they're having pelvic pain. And a lot of patients would probably benefit from a short-term referral to a PT for pelvic floor exercises. And that used to never be something we could send patients for, but it's a thing now. We can send them to PT for that. We could also send them to PT for osteoporosis prevention. Patients could be seeing 2 or 3 different kinds of physical therapists depending on the issues. So that's another one that I think we don't, want to overlook. We have patients who get pregnant a couple, 2, 3, 4 years after treatment. What are their abilities to breastfeed? And, can they breastfeed if they're still taking hormone blocking agents and whatnot? So that needs to be discussed with patients. So all sorts of issues. And I think if you ask, are you having trouble with vaginal dryness? You open that door for them to kind of share a little bit more if they're there. But if you just say, well, how's everything going? You're not going to get the answer.
That's right. And we've mentioned it, I think, before, even of just normalizing it. Could even say, well, other patients have told me this. Is this something that you're experiencing as well? So they don't feel like they're, like you said, they're not complaining about it. We're asking them, we're inviting them to bring that up because only they can tell us, but we want to make them feel comfortable and welcome to share those concerns when they are happening. Now, you've touched on this a little bit, but I think this certainly can't be overlooked, is just general lifestyle modifications, which in turn become prevention strategies. So how can oncology nurses help encourage our breast cancer survivors to engage in some of these lifestyle modifications and to promote their long-term health?
Of course, my focus has always been in prevention and genetics. So my thing is everybody should be getting a prescription for exercise, or they should be getting a prescription. We give them a prescription, they dutifully go to the pharmacy and they fill it and we hopefully take it. But then we just say something that's probably just as important. We say, well, you should exercise, but we don't give them any direction in that. And so first of all, realizing that a lot of people gain weight with breast cancer treatment. They think, oh, I got diagnosed with breast cancer. I'm going to come out of this 25 pounds lighter. And most of them come out probably 5, 10, 15 pounds heavier. And so we don't want that continued weight gain. So, at the end of active treatment, to really talk to them about the importance of this. One thing that I really like to do with patients, if you're in an area that has access to a YMCA, many of them have a program called Live Strong. And so you have to get a form signed by one of your providers that says you're good to do it. But they give them, it's a 12-week program. So they have access to the gym, all the gym for 12 weeks. And they are paired with some kind of trainer that kind of helps them depending on where they are in terms of physical fitness to say, well, this is where you're at. And this is how we're going to incrementally add to that every week. And they also kind of meet with a dietitian and kind of a life coach kind of thing. I think that says to patients many things. First of all, it says, hey, we think you're really going to do well. We want to do this. So, and many patients will stay on with the gym afterwards because, 3 months is sometimes enough to, break a bad habit. And other patients will do that. But if they can't do that, we really want them to have the goal of at least 150 minutes to up to 300 minutes of, really physical activity. And we want some strength training. And once again, if your patient is really experiencing a lot of muscle weakness, you can give them short-term PT to help with that. And I think we should. The diet issues are huge. And I think we are slow to refer to the dietitian. You can get them a couple consults, and because you're saying to them, this is really important. We need you to lose weight, or we need you to eat more of this. Ideally, fruits and vegetables are going to be about half of your plate. And what's the difference between a whole grain and not? Less processed foods, making sure that they're getting enough protein. And then once again, really kind of making sure that they're not taking a lot of supplements and extra stuff, because we don't really understand all that fully, and it could be harmful. Patients can, after some of the chemotherapy agents, they can have some skin changes that result in photosensitivity, but everybody's at risk for skin cancer. So, really talking to patients about what bad moles look like and sun protection factors with clothing and SPF and seeking shade. And that's important. Limiting alcohol. We know that alcohol can have a lot of detrimental effects. And so we want to try to do that. And of course, smoking cessation and vaccines. This is the chance for you to say, are you up to date on your vaccines? And if not, to make that happen.
Well, those are all really important, outstanding recommendations. And for this one, I always like to remind patients and their caregivers, like, this is something that caregivers can do with the patient. There are a lot of parts of breast cancer treatment that no one else can do. Only the patient can go through that one. But this is the phase where this can be done and is, I'm sure, much more successful when you partner with someone. So if you have a friend or your family member, like, both of you can increase your activity, improve your diet, do these things together. And having that support system really helps it be easier to maintain and to really hardwire into everyday life. So certainly encourage and use family and friends to be that support system, because these are hard changes for anyone to make. And so certainly something that is worthwhile and in benefits from the support of their caregivers and their care team. Well, Suzanne, we find ourselves at the end of our final episode together on this breast cancer series. And as always, we like to close out our episodes by asking a short series of these quick fire questions to help summarize what we've talked about today. So to start that off, how can healthcare professionals evaluate their hidden or their implicit bias about breast cancer survivorship?
We need to really not underestimate the impact of treatment on body image and perception. I think a lot of times when patients are choosing a surgery, they're like, oh, I don't care what I look like, it'll be fine. And I remember I was working with a religious sister, and she had had testing elsewhere, and she got transferred to St. Louis, and the breast surgeon sent her so I could organize her care because of CHEK2 variant, which was fine. And I kind of did that gentle question, how's the bra fitting? And then she's kind of like, I'm just so unhappy with the way I look and everything. And I said, well, you could see plastic surgeon and see someone about reconstruction. And I had a medical student with me who thankfully stayed silent. And she said, well, no one offered that to me. What I'm saying is, the medical student says to me afterwards, he said, well, why would you send her for that? She doesn't need plastic surgery. Her body image was altered and she needed that. So I don't think we should ever assume that just because someone's older or younger, that sexuality issues aren't a problem for them, or weight changes are not a problem for them, or maybe they are. I think you need to look at each individual and how do they see it, not how we globally think that maybe they should see it.
What are some common misconceptions about breast cancer survivorship?
A lot of times we assume that someone else is taking care of it. We assume that the medical oncologist is taking care of it, and medical oncology might assume that somebody else is taking care of it. And the survivorship care plans should help with that. But breast cancer is a very, very long journey, and making sure that nothing falls through the cracks is important. And this is where I think navigation makes a huge difference. The other thing, as we touched on, I think we really underestimate the importance and value of implementing that healthy lifestyle, because we want to delay or prevent future problems. We can't just say, oh, you should do this. We need to really get them to that point and kind of be that pest that keeps after them until we get them to that point.
What's something about this topic that's not often discussed, but you wish people knew more about?
I think we underestimate how many of these long-term issues and how they affect patients. And as I said, patients, I think, are reluctant to bring them up always because they don't want to feel like they're complaining. But we cannot assume that if they're not bringing it up, that it's not a problem. And, screening with the distress tool will help, and you can do the sub tool that might help identify a problem. But as I've said over and over again, to open that door for them and make it okay for them to talk about it is really important. I also think you can't assume, well, we gave them a survivor plan, they're good to go. Do they understand it? Can they read it? who's checking it? Those things change. Family history changes, health history changes. Maybe those recommendations were good a year ago, but maybe they're not good now. So I don't think the survivor plan is a one and done, and it's more than just checking that box so you get the accreditation.
What additional training or education do oncology nurses need to stay current on this topic?
The symptom guidelines are continually evolving and they're getting better. I mean, ONS and the NCCN both have kind of processes, and they're two of the bigger groups for doing this. And they're looking at that evidence and then issuing guidelines that are based on that evidence. So, learning to really understand and use those guidelines and not just say, well, in the past, we've always done this. It doesn't matter what we've done in the past, but really looking at that evidence. Hot flash is a great one. We'll always say, dress in layers or whatever. But there's really no evidence shows that makes a rip of difference. So we need to, say, well, this phenyloxapine's a better chance, and the evidence shows that. So really understanding those evidence-based guidelines. And I think also we need to really look at institutional processes for how we provide this care. My personal bias is that, a dedicated nurse navigator who's going to really be sorting this through with patients on a regular basis will help make a lot of these side effects not fall through the cracks. And breast cancer is a good place to start because we have a lot of those patients, but it's also then a good model for the rest of the cancer care that might be provided in an institution, but really looking at how can we make sure that patients get this from a system point of view.
And finally, what are some additional resources for patients or other healthcare providers or professionals who want to learn more?
Well, I always say stay away from Dr. Google because, wrong so often. But the American Cancer Society has some really nice for patients about symptom management. The NCCN now has patient booklets that are focused on patients, and that can be really important. ONS has a bunch of learning libraries. There's one on breast cancer. There's one on navigation. There's one on survivorship. There's one on oral medication adherence. Those are all great places to get more information. The December 2021 supplement in the Clinical Journal of Oncology is dedicated to this. And there's actually a case study in there that looks at 4 different people approaching survivorship in a patient, same patient, and all 4 of them approached it differently. So that kind of can help you to really see that there are many ways to do it, but the importance of a comprehensive approach.
Well, Suzanne, thank you so much, not even just for today's wonderful episode, but for all of the wonderful information you shared with us over the course of this series. Really have enjoyed getting to talk with you and learn so much from you, and I know our listeners feel the same. Do you have any final comments to share with our listeners?
Breast cancer is a long, long journey, and I think you should never underestimate the real difference that nurses can make. I think they can ask those tough questions, and I think ask the questions that are important to patients that patients may be reluctant to ask. I think giving patients permission to talk about those less talked about symptoms and acknowledge that those symptoms are real and that there are some strategies to mitigate those symptoms. I think that really is such a huge, important thing, and it can really help offer our patients and families hope that we can manage this a little bit better and that we are not only concerned about actual days of survival, but the quality of life that goes along with it. Thank you so much for having me.
Absolutely. Thank you. Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.